And remain standing for opening prayer.
Bow your heads with me. Kind Father, Lord, we are just grateful again, Lord, to be able to continue, Lord, in your presence and hear a message, Lord, that will help us to be better Christians, Lord, because we'll be in better health. Help us then, Lord, we pray, and we pray that all that is said and done here will be a benefit to our bodies, and our bodies to thy service. These mercies we ask and thank. In the name of thy Son, Jesus. Amen.
Okay, again, we'd like to thank you all for coming out and just taking part and being a part of this health talk this evening. Again, we'll also like to welcome our online viewers. The host of this evening's program is our very own Dr. Renee Ellis, and at this time, she will take over the program.
Thank you, LaToya. Happy Sabbath, everybody. So can we have everybody kind of come closer? I mean, you want to see this and touch it. It would be easier if you come closer. So if you could please, from the back, there's plenty of seats up here. I know some of you can't sit in these chairs because of ailments, I understand, but if you can, I invite you to come forward. I am very happy that we're able to have this program. I'm very happy that the health ministries and our church, our pastor has allowed us to open up forums like this. You know, we have people who have trouble with joint pains, and you know, all the talks that we have are tailored to, you know, the problems that our congregants face. We want to make sure that you're able to dialogue, and that's why today is a little bit more informal than per usual. Usually we have like this whole formal thing. We're gonna have a PowerPoint, but it's going to be mostly questions that we're gonna answer. Our guest speaker, he prefers to answer questions, which is why we had opened up that. We only got one question. I don't understand why. I know that people have questions today. So hopefully we have mics going around. And if you have other questions, I guess you can give it to LaToya, and later on in the program we can answer them. But feel free to ask your questions. This is for you, provided for you, okay? I'm honored to have with us today Dr. Brent Monroe. He doesn't want to be called Dr. Brent Monroe. He wants to be called Brent. He grew up in Montego Bay, Jamaica. He was born and raised Seventh-day Adventist and has dedicated a lot of time allowing the Holy Spirit to nurture his Christian faith, as he believes it has helped to shape the person he is today and will be equally important in shaping the person he hopes to become. In 2006, he graduated from Howard University with a bachelor's in biology, summa cum laude honors, and later matriculated at Howard University College of Medicine, where he won numerous academic awards and graduated with honors in 2010. He completed his orthopedic surgery residency at the University of Arizona College of Medicine in Phoenix and a spine surgery fellowship at the University of Miami Hospital Jackson Memorial Hospital. Currently, he lives in Florida, works in New Mexico, where he proudly serves a Native American community. So, incidentally, both Brent and I grew up in Montego Bay, and my father taught him chemistry. And his dad is actually really close friends with my aunt, so he's like family as far as I'm concerned. And he's a very jovial person. He's very excited to be here, and I'm very happy to have him. Brent, welcome. Can we load the PowerPoint, please?
Thank you for having me.
Hi, is this your first time here?
No, I've been here multiple times.
Okay, to worship.
Probably see me walking down the aisles, getting prayer from whoever is up here doing the midday prayer sessions. But
all right.
Prayer is powerful in my life, so any opportunity to get someone praying over me, I always grab that. So.
And he's young, right? I read all those things about him, and you would think it's somebody older, but he's young, and he believes this is his ministry as well. So very happy that he's here to share with us. Once we get the PowerPoint up, we can talk further about what we came here to talk about. So we got one question about sciatica nerve pain, and we have another. I guess we can talk about that. Did you want to start just answering questions since this is so informal? And so I think we're going to talk about this one a little bit later. So Brent, in your field of practice, what is the most common problem that you see that when people come to the clinic, not to the operating room, but to the clinic, what is the most common problem that you see?
Yeah, so in the field of orthopedics, I practice mostly spine surgery. So for me, a lot of patients will be coming in with the frequent complaint of lower back pain. Neck pain also, closely following that.
And how many people here have ever had back pain? Okay, exactly. Which is why, even though our presentation had said back and knee pain, that's one of the reasons I wanted to get questions to see how many people really wanted to talk about back pain, how many people really wanted to talk about knee pain. I got that one question, so we specifically focused on back pain, but we still will take questions on knee pain, okay? So this is the presentation. Don't let it be daunting, it's just a guide. Do we need a clicker? So obviously, with Brent being a surgeon, the most important thing that he focuses on is the management, right? If and when you need surgery, which is why it's so important for him to be here. I work in a hospital, and we deal with, okay, instead of surgery, outside of surgery, how do we deal with this? And when do you need surgery? And that's the most important thing. How do I click? Okay, thank you, sir. Okay, perfect. So, and how many people who are here who are younger than 20 years old? Okay. So most people are a little bit older, but the misconception is that back pain only affects the elderly. I was just talking to my cousin in the foyer, and he's in his teens, and he's like, oh yeah, that would be a good topic for the elderly. But it affects young and old. It says that less than 1% of all cases are serious, and this is very important. I remember working in clinic, Brent, I don't know if you've seen this, but people come into the hospital or the clinic, and they have back pain, and they're so concerned, and it's so bad, it's severe, and sometimes they can't even walk, it's so debilitating, and the question is, do I need surgery? But how many of these cases, when you see them, how many of them do you see that are actually really serious, need intervention right away, need surgery right away?
Yeah, so as I said earlier, back pain is a very common complaint that comes into the office. I think some statistics shows it being like the second most common reason someone will visit their doctor, secondary to, or closely second, to like a respiratory tract infection or something of that nature. But back pain is very frequent complaint. Most times, 90% of folks with back pain will get better within a year. So most of these complaints are very, for the patient, it is a problem, but from a structural or surgical standpoint or a medical standpoint, it is a benign reason.
Benign meaning you don't need surgery right now.
Meaning you don't need surgery, correct.
So less than 1% of cases are actually really serious. And I'm going to show you why I say that, because, I know a lot of people don't trust doctors because they don't think we know why we say what we say. I'm going to prove to you. So these are the most serious causes of back pain, right? Cauda equina syndrome. So this is when the spine collapses and it's affecting the spinal cord. Now, you come into the hospital usually for this, but at that time, you can't feel your legs. That usually comes from an injury, or sometimes somebody who has cancer and your spinal bone has collapsed on your spinal cord, and that usually needs intervention right now. Also, if you have cancer and it has spread to the bone, and the bone becomes fragile and collapses, that's pretty serious. The next one says spinal infection. Obviously, infection in the bone. is serious. And radiculopathy, which is pretty much radiation of pain from any bone injury, any collapse on the spinal cord, any collapse on any nerve, can be serious. And the other one, vertebral compression fracture, which is usually something I just talked about, where the spinal bone collapses. Now, this, I don't know if, I guess we don't need this right now, but we can show that later so people can understand. But this, you want to talk about?
Well, you talk about it, that's exactly it.
Okay. So essentially, you know, this one is the multiple color, and I got this from a neurosurgeon, but you can see up top, there are bones, the cervical bones, and usually when people talk about the bones in the neck, this is where they are. There are usually, 7 of them, and these bones, the purple ones, they can become soft and brittle and cause problems. Imagine the spinal cord is running through, so if this collapses, it can affect the spinal cord. Does that make sense? You understand? That's why I wanted people to come closer, right? Then the blue, that's thoracic, right? That's the thoracic spine, I believe, in the middle. And then the bottom, which is where people usually complain of having lower back pain, that's the lumbar. So if you think about, if you look between the bones, there's these white discs. When you talk about slip discs, that's what happens when they get slipped. Now, if you think about one of those bones being crushed, whether it's from getting cancer in the bone, and the bone gets weakened, or osteoporosis that weakens the bone, what do you think is going to happen? Right? The bone can actually compress the spinal cord, or the disc can slip from between, and infection can cause the bone to weaken. All of those things can weaken the spinal cord and cause pain and impinge on any nerve. Does that make sense? Any questions so far?
So I just interject a little bit. So as Dr. Ellis has been saying, which is correct, so most times folks will come in with pain radiating from the cervical spine, which is in purple here, and equally with either from the lumbar spine, which is in green, or a few patients will actually have what's called SI joint dysfunction, which is down here, and mimics lower back pain. So for us as clinicians, we have to listen to the patient and try to figure out what their symptoms, what's the pathophysiology, what's the source of their problem, first and foremost. Secondly, is it something that's serious, meaning we have to intervene right away, or is it something that's not that serious, we can treat them conservatively? A lot of on the last slide, the dysfunctions or the pathologies that we're showing there, those are reasons we have to act pretty much right away. But most times, that is not the reason for most back pain. Like I said, most back pain is usually because of muscle strain. So again, usually in the lower back, we have what's called the paraspinal muscles that attaches. They run alongside these spinous processes. You can feel, each of you can feel in your back, and depending on your body habitus, you may be able to feel it or not. Okay, you can feel your spinous process, and along these are muscles. So I always like to tell my patients, there, you have your skin, which is your skin, your outer layer. You have next to that a fat layer, which is underneath that. Then below the fat layer, you have muscle. And then after the muscle, you have the bone and the spinal elements. So for me, if it's something that's coming from the skin, you can most times you'll easily see it. And it's very rare for any skin condition or pathology to cause spine or back pain. Unless it's like a big, what we call lipoma, which is again, not necessarily from the skin, it's from the underlying fat tissue. But for the most part, it's usually not the skin, it's usually not the fat layer. So what's left? It's usually the muscle or the bone and the spinal elements. 90% of the time, it's the muscle. So either the patient, because of smoking habits, diabetes, because of being overweight, so when you say like a BMI over 25, patients strain their muscles because of minor twists and turns that they probably don't even notice, but by the next day or a few days after, the body knows that has happened and now reacting because there's increased inflammation in that area, and that leads to pain. If that's the case, then that usually, like I said, will get better with time and rest. And depending on the severity of the symptoms, therapeutic interventions that the doctor will recommend. If it's something more serious, then now we are talking about something that's involving those bones, which is the bony spinous process, or the elements of the vertebral body, or the contents within the neural elements. And in that case, that's when we're talking about the Cauda equina, we are talking about the vertebral compression fractures, we're talking about infections, we're talking about metastatic tumors, et cetera, et cetera.
So
I'll just stop. I keep want to go back a little bit. So this for us is a medical emergency. So someone comes in the Cauda equina, the clock is ticking. I have to get that person to surgery, and I have to decompress their spine immediately because the studies show that within the first 24 to 48 hours, that's the most crucial. If you don't get a chance to decompress them, then that person will have permanent paralysis or will have some loss of muscle strength in whatever dermatomal or muscle distribution that the nerve that's supplying is being compressed. So usually, everyone here, most of us, our spinal cord ends around L1, L2 for males, and usually for females, it's around T12, L1. So this is the last thoracic level, which is T12. Then you begin the lumbar, which is the L1. And so between T12 and L1, that's where, for females, usually their spinal cord ends, and then for males, it's one level below that, L1, L2. And below that, you have spinal nerves. And it gets the name Cauda equina, Cauda meaning lower, equina coming from the Latin word for horses. So it looks like a horse's tail when you look at it on an MRI. And so if the horse's tail gets compressed because of spinal tumor, infection, collapsed bone from a fracture, or a disc herniation, then that's usually when you have loss of function in your lower extremity. And we're talking about severe weakness. We're talking about what we call saddle anesthesia, meaning your perineal area between if you're ranging from your groin area all the way back to your buttock, it becomes extremely numb. And then you start having what's urinary retention. Most patient comes in and they're saying, oh, I'm going on myself, I can't. Usually that's not a concern for us per se from an emergency or urgency standpoint, but when patients start having retention, that's a flag, that's a red flag for us, because now they can't expel their urine. And so for us, someone's coming with saddle anesthesia, urinary retention, significant weakness in their lower extremity, MRI stat, because we need to know what level they're having Cauda equina. And again, usually because of where the spinal cord ends, it's usually anywhere from L2 all the way, it could be L1 also, but usually L2 all the way down to the sacrum, most often from L4 down to S1. S1 meaning, in this case, sacrum. So the sacral spine starting with the orange that we see right here. So that's the problematic area. And again, most times, outside of cancer or infection, it's because of a large disc herniation that is now compressing the nerve. And now the race is against time for us to take that person to surgery. But again, most times patients coming into the office, they do not have Cauda equina.
So just wanted to remind you that the ones that we're talking about are ones that are the most serious, the 1% of cases that we don't want to be missed. And I'm bringing this to awareness because, when you have back pain that started yesterday and you can't move, the first thing you're thinking is the worst thing. And so we want to bring this awareness. And it's very important what he brought up, that you can't feel the perineal area, meaning if you try to go to the bathroom, you can't feel that whole area. And that's a huge red flag. That is very serious, usually. So that's important to note. Do you want to talk about?
Yeah, metastatic cancer. So most times, the most common metastatic cancer to the spine is usually breast cancer or lung cancer. You have other cancers that can go like prostate and liver or colon cancer. But by and large and far, the most common is breast and lung. It can be anywhere in the spine. We're usually thoracic or lumbar spine. If that happens, then depending on where the tumor has metastasized to, then that decides what we need to do as surgeons. You know, if it's in the vertebral body, which is the front part of the spine, then depending on how much of the vertebral body is consumed by that tumor will determine what we do. If it's in the posterior aspect of the spine, again, depending on how much of that spine is compromised, we have to decide what we do in that case. If it's inside the spinal column, which is inside where this yellow portion is, then again, depending on what's going on. So it usually involves either some type of chemo radiation to decrease the size of that tumor, and then we're going in to clean out the remaining portions. Usually the plus or minus what we call a fusion. So we have to put screws and rods to stabilize the spine. So it's kind of like if you have a tower or a building with 4 columns and you take out 2 of those columns, then chances are that building is going to tip over. So we go in and we clean out that tumor, and now 2 of those columns are gone. We have to put supportive beams, in this case screws and rods, to hold up that building, in this case to hold up your spine, or maintain the integrity of that spine.
And I'm glad we're talking about this because I know people in our congregation are suffering from cancers, and I bring up prostate because it's a very common one in our community, unfortunately, and breast cancer. So if you have cancer and you're being treated and you suddenly develop back pain, you definitely need to let your doctor know, because the cancer spreads so easily or usually to the spine. And this is usually one of the first symptoms that you'll have is back pain.
And I kind of jumped ahead a little bit also, but most times when a patient comes in with a metastatic lesion to their spine, a lot of times we're not the sole clinician making that decision. We have the oncologists, the hematologists, we have the radiologists, we have a group of us that are usually coming together and deciding, because one, we have to know the prognosis of that patient. How long, if that patient is their life expectancy is 3 months, then usually we are not operating, because they're gonna be miserable for that last 3 months of their life. And so, but if the prognosis is, say, over 6 months or more, then again, depending on what needs to be done, we'll make that decision if it's worth that, if it's in the benefit of that patient's rest of their life or longevity to operate. So it's not just as straightforward, they have a metastatic disease to their spine, we're just gonna go operate. No, there's a number of things that we take in consideration.
Okay. And then infection.
So spinal infection, most times we see an infection in what we IV drug users. Those are probably the most, in my experience, the most common patients that we because they usually do not clean their skin before they inject, and so they inoculate their bloodstreams with bacteria that lives on their skin, which normally would not cause an issue, but now it's inside the bloodstream. And it usually goes to an area that is not well protected. So just like any foreign army or any enemy, they like to invade your point of weakness. And in the spine, the point of weakness is the intervertebral space, the disc space. So the disc space, these clear or whitish looking area in between the vertebral bodies, in between the bones, they're what we call avascular, meaning they do not have blood supply. So a bacteria can go there and essentially hide out and replicate, reproduce, and grow. And by the time it starts spreading, it has caused so much damage that the patient has this back pain, and we look at an X-ray, and within a couple days or hours, their spine just starts degenerating, collapsing, and depending again on the extent of it, we have to make that decision with the infectious disease doctor and the hospitalist, the best course for this patient. Do we treat them with IV medication, or do we have to go in as spine surgeons to clean out the infection, to get it to reduce the burden of the bacterial load, whereas now we can start IV medication. So what a lot of people, or the misconception is that the surgery is what kills the bacteria, or what resolves the infection. No, what surgery, we have the saying when we operate, the solution to pollution is dilution. So what that means is we're saying pollution in this case is the infection. And the solution for that is diluting the colonies of bacteria. So, so just using an arbitrary number, you have 100 bacteria. Maybe in the body, again, I'm trying to be as simple as I can here. So you have 100 bacteria. In the body, you have 20 white blood cells. Obviously, the 100 bacteria is going to overwhelm the 20 white blood cells. Or they may be hiding in areas where those 20 white blood cells can't get to. What surgery does is we go in and we reduce the burden. We go in and we use irrigation, we use solutions, and also instruments to debride the bacteria. So we reduce that load from 100 to, say, 20 or 19 or 15, or we reduce it to a number where the body now, in addition to the IV antibiotics that they're using or the hospital is using, can now properly or effectively resolve that infection. So the surgery by itself, a lot of times, is not the reason or the sole reason why the infection is being resolved. Because a lot of times, if we just did the surgery and that was it, the patient did nothing else, what's going to happen is the bacterial load is going to build right back up. So that we reduce it to a certain number where now the antibiotics and the patient's body can effectively fight that infection. So it's a combination of the IV antibiotics and the surgical debridement that effectively gets rid of the agent, in this case, the microorganism, the bacteria.
Right, and spinal infection can come about. I don't know if anybody here is on dialysis. If you're on dialysis, you're at risk. If you've ever had a blood infection, and I've seen blood infections occur as simple as having a urinary tract infection that turns into a blood infection. And that's why treating any blood infection is so important, because as Dr. Monroe said, these bacteria can hide. So it's very important. If you unfortunately have a blood infection, you get that adequately treated, finish all the antibiotic that you're given. If you're on dialysis, they have to be so careful. If you get any IV drip consistently, you have to be so careful. Introducing bacteria into your system can lead to something as serious as spinal infection.
And I know we were talking about spine, but it's the same reason why a lot of patients, especially where I'm at in New Mexico on the Indian Navajo Reservation, where they will come in because the diabetes is very prevalent there. So they'll come in and they'll have a raging swollen knee, and we go into surgery, we cut it open, and it's just pus pouring out. Because again, the knee joint is an area where it's relatively avascular, there's not a lot of good blood supply, and so the bacteria likes to find areas around your bodies that are like that. So your shoulder joint, your elbow joint, your spine in the disc space, your knee joints, hip joints, very, very common. Radiculopathy. So again, most times radiculopathy is usually what we call unilateral. It's usually on one side. And the classic thing is, they'll say, my sciatica is acting up. Like, you have pain running down this one leg and it just goes down the back of my leg to my foot. A lot of times that's because there's a pinched nerve, and that is what's radiculopathy. Most times it happens to one leg, which is a unilateral, but it can happen to both. But it usually involves, and I like this model because it gives you a good example. So here we can see a disc herniation. Disc herniations are not the only reason you have radiculopathy, by the way, but in this case, just using this example. You see the disc herniation here. And to understand what a disc herniation is, I like to tell my patients, you think of a jelly donut. Everyone likes jelly donut. I do, hopefully. But for whoever's eating a jelly donut, you know that if you squeeze on that donut, you can squirt that jelly out, right? You can, if you forcefully squeeze, you can pop that dough, and that jelly will come squirting out. And essentially, that's what has happened when you have a disc herniation. You have the annulus, which is the dough of the disc, and then inside you have the nucleus pulposus, which is the jelly. And depending on whatever reason, it could be repetitive micro injuries or just everyday wear and tear, or as guys like to go in the gym and show off, they try to lift the heaviest weight, try to do a deadlift, and you could, for different reasons, herniate a disc. In this case, cause a tear or a hole in the annulus, and now you have the jelly that's squirting out. And what happens is that jelly can now push against the nerve that is either going down the Cauda equina, okay, or the nerve that is exiting the spine. I like to tell my patients that if you think of the nerves in the spine as a room like this, so the nerves are all in a room, and at every level, a couple nerves have to exit that room. It's like the body says it's time for you to go out. And so they go out through the door. So you can get compression within the room, or you can get compression as you're going out through the door. So most times, radiculopathy is usually for a single nerve that is inside the room in its little space. The body, or in this case, a disc herniation has occurred, and it's compressing that nerve, or it gets compressed as it's going out through the door, or in this case, through the foramen, the hole in the side of the spine between the bones, and that's what you have radicular. So usually it's one nerve root, and people will describe a pain going down their legs, and based on their description to a doctor can sometimes, we can identify which nerve it is. But most times we get an MRI, and the MRI will confirm exactly what we're thinking and also confirm the nerve. But just listening to the patient, a lot of time we can figure out before the MRI exactly which nerve it's being compressed. And again, depending on the severity, will determine what course of action we take. There are other reasons you could have radiculopathy. It could be because of, it could be because of a tumor, could be because of infection. All those things can cause radiculopathy also. And it also could be because of bone spurs. But usually, those are more, we call it insidious onset. It's more slowly over time, as opposed to someone having a sudden onset, which is usually from a disc herniation, and usually a younger patient. Probably usually somebody who was at the gym too, or who was lifting in a warehouse, lifting something heavy. A lot of times patients will come in, I was moving furniture, I was cleaning and stuff like that, and then all of a sudden I started having pain shooting down my legs, and my sciatica is acting up.
We'll talk further about that. Vertebral compression fractures.
Yeah, so vertebral compression fracture is a common reason for back pain. I wouldn't necessarily it is a serious reason, because it signals that that patient, by definition, someone with a vertebral compression fracture has osteoporosis. So even if you've never been diagnosed with osteoporosis, if you get a vertebral compression fracture, then by definition, that is osteoporosis, because you should not just be breaking bones in your back without any type of serious trauma.
So tell them what osteoporosis is.
Yeah, so osteoporosis is, so your bones are made up of calcium and phosphate. And so that's what we call the inorganic portion of your bone. You have an organic portion and inorganic. The organic portion is mostly collagen, or the inorganic is mostly calcium, phosphorus. That's why we say take your calcium, take your phosphorus, take your vitamin D. Not necessarily that vitamin D is part of the bone, but vitamin D helps the body to absorb that calcium. And so usually if you don't have enough calcium or phosphorus within the bone, or indirectly enough vitamin D, then the quality of that bone is not what it should be, and in that case, that's osteoporosis. So it's more of a quantity issue. You don't have enough, as opposed to a quality issue, which we see growing up in the Caribbean. We see kids with what we call bow legs. I don't know if anyone here plays soccer. We used to love the bow legs kicks. So you could kick the ball through their legs, right? But as I became a physician, I realized that that is not necessarily a good thing for that person, because a lot of times we do have physiologic bowing of the leg, but a lot of times, especially in third world countries, because of what we call rickets, and then in older patient, we call it, it's the same thing, but we call it osteomalacia, which in that case, it's not the quantity, in that case, it's the quality. So in other words, they have enough building blocks, but the building blocks are not made enough, they're not being constructed properly. Where in osteoporosis, there's just not enough building blocks. So the building blocks that are there are good, but they're just not enough. So in other words, it's a quantity issue. So that's why osteoporosis is something that it's treatable because you're just trying to get the quantity back in this case. But I won't get into the medications for that. But the best way, believe it or not, to treat osteoporosis is one, preventing it. So we have to tell our young boys and girls, so it's not only females that it affects males too, especially after they hit 60 or 70 and the testosterone starts dropping in their bodies. So it's not just erectile dysfunction that they have to worry about now, they have to worry about weaker bones in addition to that drop in testosterone. And for females after menopause, for the same reason, drop in estrogen. And so in this case, the best way to treat it is actually to prevent it. So most females will build their bones up until age 25. And so if you're starting from a very high level, meaning you've built your bone up to for it to fall all the way back down to the level where it gets to osteoporosis, it's going to take longer, right? So that's why it's important to encourage our young females to do what we call weight-bearing exercises. So you go into the gym, you do leg presses, you lift weights, and again, safe weights. Again, because everything in life is moderation. So we're talking about safe weights, not weights to brag and say you're the strongest in the gym, but lifting safe weights, doing controlled exercises, and building that bone mass as best as you can. It's almost think of it like what Joseph recommended to Pharaoh. In the years of plenty, save as much as you can, so that the years of drought, we have enough to cover ourselves. So it's the same thing. In the years when the young males are growing, you want to build up your bone mass as much as you can, so that in the later years, you have enough to survive before it hits the point of osteoporosis. And so most patients that get a vertebral compression fracture, by definition, have osteoporosis. And vertebral compression fractures, like I said, by themselves is a problem, but usually, by definition, it is not something that we have to necessarily operate on. There are a few criteria that me as a spine surgeon has to know, but I won't get into it today. But in general, vertebral compression fractures are not a structural issue. It can become, but by itself, if they have what's now called a burst fracture, which in this case, the vertebral body splits open and starts pushing against the nerves inside the spinal column, then that can be a surgical emergency. And we may have to act sooner rather than later, along the same lines of what we discussed with Cauda equina. But vertebral compression fracture do cause significant lower back pain. It is a big problem because a lot of, especially, I forgot the number, but I would say, I think it was either up to 70 or 80% of our older patients with lower back pain, a lot of those patients is because of a vertebral compression fracture that is misdiagnosed. So a lot of our older patients go to their doctor complaining of lower back pain, and because the doctor knows that a lot of times it's benign reasons, like we said earlier, back muscle strain, and they reassure them and say it'll get better with time, which it will get better with time, but they have missed a major diagnosis because one vertebral compression fracture increases your chance significantly of having a second vertebral compression fracture. And not only that, but now you have an increased chance of having other pathologic fractures. In this case, wrist fractures. They fall, they break their wrists, which I see a lot in New Mexico, especially when it gets icy during the winter season. And also hip fracture, which is significant because now the mortality and morbidity significantly increases. You get a hip fracture and there's a 50% mortality, not to mention the morbidity that comes with that. So it's it's very important that clinician gets that diagnosis, because now they need to refer that patient to get evaluated for osteoporosis to see exactly where the quality of their bone is, to now start treating it so that they can prevent that person from having more serious osteoporotic fractures, whether in their spine or in their hips or their wrists. So yes, the vertebral compression fracture by itself is not something that I would rush and take a patient to the operating room for, but it's still a major diagnosis that we have to, as clinicians, have to catch, because it signals that that patient has osteoporosis and needs to get treated. So if there's anyone here, essentially what I'm trying to say, if there's anyone here that has a vertebral compression fracture, know of someone that has a vertebral compression fracture that has not gotten treated, that is not a good thing. If you know you have osteoporosis, you're not getting treated, that is not a good thing going forward.
And you can develop osteoporosis if you've been on steroids repetitively or for over a long time. Like people who have asthma, you have COPD, you take steroids for whatever reason, and you've been taking it for long term because it makes your bones brittle, which is what osteoporosis pretty much is. I think we belabeled this in the sciatica we talked about.
Yeah, so like I said, the sciatic nerve is the largest nerve in your body. It's the largest and longest nerve in your body. It goes from your lower back all the way down to your foot. And so a lot of times people will say my sciatica is acting up, and it's all the nerves in the spine. There's a number of nerves that come together to form the sciatic nerve. And so you know, we're looking, for example, the lumbar nerves here, the lower lumbar nerves plus the sacral nerve, that together forms the sciatic nerve. And it comes out through this little area in the spine right here that's called the sciatic notch, okay? And right alongside that nerve is also a muscle that right alongside it that's called the piriformis muscle. And so a lot of times you'll hear patients say, it's my sciatica, or sometimes you hear it's a piriformis syndrome, and that's okay. But us as surgeons, as clinicians, we have to know exactly what is going on. Yes, it's along the sciatic distribution, but exactly which nerve, because one nerve getting pinched will cause the symptoms or feeling of sciatica. And we can't assume that it's just, because a lot of times when patients are saying sciatica, they think the problem is coming from right here. Right here, my sciatica. And I try to tell them, nope, it's coming from your back. And they look at me weird, like, this doctor don't know what I'm gonna say. But then I have to explain to them what's going on. That it is they're feeling the pain and stuff in the in the trunk, but it's the branches of that tree that's coming together, going in reverse, that's forming that trunk. And the issue is not the entire trunk per se, but it's one of the branch that there's an issue. And once we treat that branch, then they will not have that symptom going down in the trunk, going down the legs. So sciatica is just a broad term that everyone uses to describe any pain that's in their lower back or anything that's going down the legs, which, again, for a layman, for a layperson, that's okay. But us as surgeons, as clinicians, we have to know the difference and know exactly what's causing that issue.
I think somebody asked a question about sciatica.
Yes.
Is that person here? Nope. Okay. We're going to revisit it later.
I think.
Oh, she did? About the sciatica? Something else?
Have a mic?
No, ma'am.
Thank you. Yes, Doc, it seems as if I'm the only one here with my kind of pain, because you mentioned all the other pains, but not mine.
Which one is yours?
I've got rheumatic,
Rheumatoid arthritis?
Rheumatoid arthritis. And everything on my right side hurts, but everything on my left side is good. So I need something on that subject, please.
So normally rheumatoid arthritis is a systemic problem for me as a surgeon, as a clinician, I would be not that I'm ignoring the rheumatoid arthritis, but if you're telling me that your pain is only on one side of your body and not on the other side, then rheumatoid arthritis being the primary reason is low on my radar. I would be looking inside your brain or inside your spine to find something that's affecting one side of your body and not necessarily the other side, because usually rheumatoid arthritis does not selectively affect one side of your body and just completely ignores the other side. So I would have to get imaging, you'd have to take a more detailed workup, but rheumatoid arthritis as the underlying reason, it could be a contributing factor, but it would be low on my radar as the reason why you're having issues on one side of your body versus the other. But what can affect one side of your body, if you remember what I said earlier, was radiculopathy. So radiculopathy meaning nerves get impinged on one side, or there's something affecting the spinal cord on one side, or something affecting your brain on one side that can lead to symptoms on one side of your body, and the other side being, that'll be more likely the reasons for your issues.
Yeah, we should talk further, because are you seeing a rheumatologist? Have you got rheumatoid workup done? Oh.
All kind of tests and came back with it. It says it's rheumatoid arthritis. The right knee is swollen and stiff.
Okay.
The right shoulder,
Okay.
I can't wash my back.
Okay.
So even my right eye hurt, and the left eye doesn't hurt.
Okay. So rheumatoid arthritis is it's an inflammation. It's an inflammatory problem. So you only got painkillers. There's nothing else. No other anti-inflammatory. An injection in the knee.
Prevent the bones rubbing.
Okay.
And then my doctor, I changed doctor, and then this doctor would not give me the referral to see my rheumatoid doctor, and it all got worse.
So did the knee injection help you?
Pardon? That was years ago. They stopped doing that because they said that injection could have some effect on the bone.
So have you gone back?
Hmm?
Have you gone back to see them?
So in your case, I don't want to assume. I imagine you're in your 80s or 90s. So a lot of times when we tell a patient that the injection affects their bones, what it means is, what we are trying to say is, like a injection into the knee joint, the shoulder joint, it's usually a steroid injection, and
Yes,
that's usually what we're talking about.
Yeah.
It's usually a mixture of steroids, of a numbing medication, like an anesthetic like lidocaine, and some other medication, anti-inflammatories. But usually, the one when you're saying affect the bone, they're usually talking about the steroids. So what the steroids can do is, the steroids can cause cartilage damage in large quantities.
Yeah.
It can cause what we call the death of chondrocytes. Chondrocytes are the cells that forms the cartilage in your knee. And so for a younger patient, we are very careful of giving them steroids, because it can have a negative effect. It can, even though it's calming down the inflammation, it can also cause death to the chondrocytes. And so we are very careful about giving younger patients. In your case, I would not hesitate to give a knee injection. I have zero concerns about chondrocytes dying, because in your case, I'm more concerned about treating your pain and treating the symptoms that you're coming in with, as opposed to worrying, because the reality is you have more years behind you than you have in front of you. So,
Not,
sorry if I stepped on, if that was a political wrong way of saying that. So, in your case, my goal is to make sure you walk out of my office satisfied. And in this case, I have zero concerns about chondrocytes dying. And so unless there's other reasons which I don't know about your medical history, you will be an ideal candidate for injection because, again, my goal is to treat your symptoms and at your age to avoid the operating room. Because I do not want to take you to the operating room and cause a complication to send you to your grave sooner than the Lord.
So, where is your office?
I mean, for rheumatoid arthritis, somebody's talking?
Where is your office?
The hospital.
Where's your practice?
Oh, you want him to give you the injection?
No, I want to visit his office.
You want to visit his office?
Yeah.
It's in New Mexico.
But we can give you referrals. But, he made a good point that, okay, so rheumatoid arthritis, usually I see much younger patients. I'm not saying we don't see it in people as young as you are. But usually, the treatment is anti-inflammatories, and not just injections, but we give steroids, right? Because it's an inflammatory problem. The body is essentially attacking itself, right? It's an autoimmune problem. The body is affecting itself, and so you have the body affecting the joints, and you have joint pain, right? So we give anti-inflammatories, and you see these commercials for all these, I think Remicade is one of them, all of these medications that we give, which is why I asked her if she went to a rheumatologist, because they would have recommended what would be appropriate for her. Some of them are more expensive, a lot of them suppress the immune system, and once the immune system is suppressed, there can be so many problems that happen. So these medications have risk benefits, and which is why age is such a big factor. So we don't mean to be indelicate, but age matters.
It does.
All right?
Yes, hopefully, yeah.
Okay, go ahead.
I think I see a number.
Did we answer your question? I'm sorry. I know you still have some. So, okay.
But just to wrap, I think you're an ideal candidate for injections. And again, I would have to look at x-rays to see what's going on, to make sure, one, I don't go down a rabbit hole to say it's arthritis. But if indeed it is arthritis that's affecting your shoulder joints and your knee joint, then I would not hesitate to try injections on you.
Okay, I see you have inflammatory arthritis up there.
Go ahead.
Okay, and so I just want to put in the mix the AS, because that one goes straight to give you the back pain. Let me see if I can pronounce it.
The ailments?
Ankylosing spondyl.
Oh, okay.
Right. So that AS coupled with RA can give you some really terrible experience. And to the point where you can't really move, right? And there is the neck, there's the shoulders, there's the back, and the prognosis sometimes for the AS, it seems if you don't have it under control, you can lead to some fusion of this, and it is, but it's very painful. Back to the injection, that doesn't help. So maybe I am a candidate for the injection, but it doesn't help. The steroids doesn't help.
So is it, when you say steroids with AS, so just for everyone who's, so she's talking about ankylosing spondylitis, which is an autoimmune issue where the body fights against itself and causes increased inflammation that now affects the joints. It affects the spine a lot. So my one question to you is, when you say injections, because...
Steroids.
But which joints are we talking about? Are we talking about the spine, or are we talking about the hip, the knee? Because if we're talking about the spine, you're correct. It won't work because we cannot inject. Look at all the joints in the spine right here.
No.
Look at all the multiple joints.
No.
And so even if you inject one joint, it will not work.
No.
If you're talking about the hips or the knees, that could be
Yeah.
different.
There is no attempt to inject for the spine. Occasionally, it's for the knees.
Okay.
But then they're not going to do that again because that doesn't help. So, but what I'm saying is that I am wondering what can be done. What can I do? You just your body is just riddled, you know, with AS and RA. And I wouldn't bother tell you the third one because it's some of the similars for all three of them. They're all similar. The symptoms for all three, you might find similar symptoms across these three autoimmune problems, and you don't know which one you're fighting when you're fighting. I must say that my diet and exercise seem to be to help. So one of the things that you have to do is the rest, the diet, the exercise, and if you are messing up there, there is a problem. For me, soy, gluten, dairy, things trigger. And I'm not sure if they are triggering the problem with the AS, the RA, the whatever the third one is, that I won't name. I don't know if they are triggering that or they are separate and independent. So I don't know, doctor, what to do.
So I wanted to get a naturopathic physician here today. I don't know if he showed up yet, because I agree with you. Diet is very important, and I usually tell patients to keep a diet journal and see what works for you. But it sounds like you have multiple autoimmune-related problems. I hope you're following with a rheumatologist, and they have like all the file work on you and see. I do have friends who have rheumatoid arthritis, and there are medications that work for them. I also know that. Do you wake up stiff in the morning? Because that's one of the hallmark features of rheumatoid where, that was on one of the slides coming up.
Yeah, I'm stiff in the morning, but I'm sitting here and my neck, to move it, to walk. I mean, I come out here today and I'm walking around and looking good, I hope. But that is with a lot of discomfort, right?
Right. Have you done swimming?
No, I've not done swimming in a long while. But I do have some really good medication. One of them, but they of themselves have their side effects.
Right.
So one of them reduces my immune system. Yeah. And so any little thing that I have buried there will flare up, right? I don't know if you know the drug Adlima. You might have it by another name, but it is very good. I must say that helped me to be able to literally walk because I could not move. So I'm able to walk. I got that for the AS. I'm able to walk. I got another one for the other arthritis. So I'm walking and I'm moving. But the quality of life, it's just not there, right? So I have a new rheumatologist. They're all good. They were all good to me. And I have a new one, and he's just said, okay.
Is he local? You can refer him to...
No, because I'm coming from Canada.
Oh, okay.
And he says, when you get back, we are going to be doing X, Y, and Z. So it's good to have a good rheumatologist. That's the first thing. I need a good rheumatologist and one that is not annoyed with you being in his office to just flop you off.
Okay, thank you. I wanted to go into the, I think we already started with the other causes of pain, back pain mainly, but not as serious, but very common. And I think this is a big one. You agree, Dr. Monroe, I'm sure.
Which one?
Arthritis.
Oh, yes.
Sure. We're doing questions.
Oh, I'm sorry.
Sure.
I just wanted to comment on the rheumatoid arthritis, because once I had some pain in my knee, and they referred me to you, the orthopedic surgeon, and he prepared to do surgery, but there was confusion with the referral, and my PCP kept on sending the referral, and it never, I was sitting in the office, and it never got there. And then I said, no, this is a sign. And I never did any surgery, and the pain went away. You know, but since I have the mic, I just want to ask if neuropathy is, because they referred me to orthopedic for neuropathy. So, you know, if you get a chance, you can explain neuropathy for me, please. Thanks.
Yeah. I'll just make one quick comment. Anyone that you walk into their office and the first thing that they're recommending is surgery, be very careful, especially orthopedics, or in this case, spine surgery. The most lucrative fields or parts of medicine is spine surgery. You make a ton of money by operating and putting hardware inside of people. And so you'll go, they'll tell you need a spinal cord stimulator, you need fusion, you need this, you need that. Be very, very careful. It's okay to get a second and a third, and if you really want, a fourth opinion. So just be careful of coming into an office and recommending. That's why a lot of times we're highlighting the red flags. So if you don't have those red flags that we're talking about, do not let anyone operate on you the first time you're seeing them, or even the second time. Be very, very, and if you're not sure, and you see me around here, come ask me. I'll be more than happy. I think God will be okay to do a Sabbath consult with you and tell you yes or no, you should do this or not do that. But be very careful of someone operating on you the first time they see you.
I think somebody else had a question. I guess we're fielding questions, and we'll ignore this for now. All right, go ahead. I think...
Doc, can you expound on spinal stenosis?
Spinal stenosis?
Spinal stenosis.
Spinal stenosis.
Yes, so spinal stenosis is, we kind of touched on it. So what stenosis means compression. It means there's the nerve, the spinal elements are getting compressed. So when we talked about Cauda, Equina, when we talked about lumbar radiculopathy, disc herniations, that's usually along the lines of spinal stenosis. A lot of times, specifically though, when someone says spinal stenosis, they're not necessarily talking about compression going through the door. They're talking about compression within the room. So again, if you think of the analogy, so within the spinal cord, within the spinal column. So inside where I'm touching right here, inside here. And usually the nerves are given a space that they can operate and move. And if that space is taken away, is encroached, then that's spinal stenosis. And there's different degrees. So there's mild, moderate, severe. And so depending on what the MRI is showing, you may hear this person has mild spinal stenosis, moderate spinal stenosis, severe spinal stenosis. And it just means that the space inside the room, inside the spinal column, has been taken away and the nerves are becoming encroached. Okay.
And I've heard people say that when they have spinal stenosis, if they lean forward or if they're going up steps, it relieves it.
Yeah, so you get most space in your spine in flexion. What flexion is leaning forward. So you'll have a lot of patients, we call it the shopping cart sign. Patient will come in and say, Doc, I'm okay when I'm in the supermarket. I'm fine. And that's because they're leaning forward on their shopping cart. And they'll tell you, but the minute they raise up, that's when they have pain. And the reason for that is it could be twofold. One, it could be because again, when you're in extension, you're decreasing the room, and so your spinal stenosis is worse. So meaning you're making that room even more compressed, even tighter. The other reason is if you have arthritis or facet pain, then look what happens. When I bend this spine like this, you see what happens to the joints? They distract. But when I go erect, so meaning move the spine erect, what happens to the joints? They close down. So if you have arthritis in those joints, what do you think is going to happen? It's going to get worse. It's going to hurt. So when they stand up, it gets worse, okay? But keep in mind, there are other reasons that causes back pain where patient will tell you, doc, when I go forward, that's worse. And when I stand up, that's better. Because also a patient could be having other conditions. I'm sure you guys have heard of what we call it colloquially a slip disc. Everyone's heard of slip disc? You've had it, right. And so in that case, that's the medical terminology for that is spondylolisthesis. And that's a slip disc where one vertebra has moved out of alignment with the other vertebra. And that's a very, very common cause of back pain also, because that person has instability. And so whether they're bending, whether they're going backwards, a lot of times they'll tell you, I have pain all direction. When I'm laying in bed, when I'm moving, and you get an x-ray and you see that they have a slip disc. That vertebral body has moved relative to the one above or below it. And so in that case, depending on, again, on the severity of the slip disc, we have to treat them. And usually, most times, those patients, especially the more severe ones, those patients will end up needing a surgery because they have that instability, and nothing outside of surgery per se can help that instability. Okay?
Doc, my pain is in the right side of my neck, which radiates down to my right shoulder. I do have arthritis, and I have both knees replaced. I have no problem there. All my pain is in the right side of my neck, radiates down to my shoulder. So, again, usually when a patient comes to me with a specific, clear-cut symptom profile or complaint like that, those are usually patients that, like you, that do have a problem. When a patient comes and like, it hurts here, everywhere, usually that's the patient that's hardest to treat because it's hard to find a reason. So a patient that comes to me with your complaint, I have two things on the top of my differential diagnosis is it's either cervical radiculopathy, meaning these nerves coming out the side of the spine here. On the right side is getting pinched, just like he got pinched. We were describing how he got pinched down here when it was going through the door or inside the room. So it could be one of those, so cervical radiculopathy. Or a lot of time patients have intrinsic shoulder pain that radiates up to their neck. And so they can have what's called subacromial impingement, meaning the rotator cuff is getting impinged when they and a lot of times those patients will tell you, I'm okay with my arms down here. But the minute I try to raise my arm up and try to do anything, that's when my pain just starts shooting all over. Impingement as opposed to radiculopathy. But those are the two things that come to my mind with your complaint. And so if it's something that bothers you a lot, then that's something I would highly recommend that you get evaluated for. In this case, x-ray of your neck or x-ray of your shoulders. And based on what those two things show, in addition to a clinical exam, because the doctor has to now put their hands on you and move you around. That's the other thing. If you go to a doctor's office and they're recommending surgery and they have not even touched you, then you want to be careful again. Because it's very important to touch the patient and move that particular, not to elicit the pain or cause the pain to be exacerbated, but in a way where you can try to understand more what their pain is.
So I wanted to segue into osteoarthritis because of questions we're getting, especially the one that you just gave us and one that we got, I think, on the internet. Osteoarthritis, right? This is one of the common things that people have, bone on bone, right? Why is it happening, wearing away over time, and what to do about it? This is a big question, and you have a question there as well.
Yeah, so here's a question. When does severe non-painful knee crepitus
warrant medical intervention in a younger person under age 50? And then the follow-up to that is, are there interventions to decrease the crepitus before the joint becomes painful? So non-painful crepitus is not an issue. I know that it's been out there that if you crack your knuckles and stuff, that eventually that can cause trauma. And there's sides for back and forth, pro and cons on that. But in general, crepitus, just to explain to those who don't know what crepitus is when you move your knees or your joint, you hear the creaky sound. People say, hear a lot of, oh yeah. So in the absence of pain, that is okay. What it just means there's air in the joint. There's air that has gone in the joint, and you're just hearing that air when you move it. But it is not a reason for concern. It is not a reason for any type of intervention unless, again, there is pain or we get an x-ray for another reason or something and we see some type of pathology on that x-ray. So whoever asked that question about crepitus in a non-painful joint, I would reassure them that that is no cause for concern. Just go about your daily life, build up your bone mass depending on your age you are, and eat healthy, eat a lot of food, turmeric, a lot of food that's antioxidant, that reduces inflammation, and you should be fine. So keep in mind though, some people can have crepitus with arthritis, but it's not the crepitus that has caused the arthritis. So I just want to make sure I make that clear. It is not the crepitus that has caused it. It is not related, has nothing to do with the arthritis. Okay? It's the crepitus by itself is not an issue. Okay, but if you do have arthritis, then that's another issue that we have to address.
While you're reading that, you have
Say,
a
how long does it take a fracture, neck and spine to heal? And if you were told you have a cyst in your knee and you are always in pain and it gets swollen often, should it be operated on or not? So first question, how long does it take a fracture? So for spine, because the spine is, it surrounds your spinal elements. In general, the younger you are, the faster things heal. So you can have, I'll just use the example of long bone fractures, your radius, your femur, your tibia. For kids, it's usually anywhere from 4 to 6 weeks. Adults, usually 6 to 8 weeks. We get a little older, we tell them, okay, more along the 8-week mark. But in general, bones on average, we say it takes about 6 weeks to heal. A little sooner for younger patients, a little longer or more time for older patients. But on average, 6 weeks is a very good number. When it comes to spine, it's the same thing. But we as spine surgeon will tend to be a lot more cautious. Again, because we want to make sure that it is completely healed, because if things are not healed, what's at risk is a person being paralyzed. And so neck fracture, again, depending on what it is, we may immobilize someone up to 12 weeks. Again, because we want to be certain that that fracture has healed, because if not, it could be the difference between paralysis or not, as opposed to a long bone fracture, meaning your radius, your ulna, your humerus, your femur, your tibia. We may allow you to start weight bearing, because in this case, a lot of times weight bearing stimulates healing. And even if there's a little shift, because it hasn't fully healed, it's not going to cause any detrimental issue, because your body will remodel. And so we tend to be a lot more lax or looser with long bone fractures as opposed to spinal fractures. So to answer this person, anywhere from 6 to 12 weeks will immobilize a spine for, depending on what kind of fracture it is. And then the next question is a cyst in the knee. So usually we get cysts in our knees because of advanced osteoarthritis, usually. I mean, you can have cysts for different reasons. There's a lot of malignant cysts. There's a lot of different types of cysts, but I'm assuming this person is talking about a cyst that's because of arthritis. And a lot of times, people get what's called also a Baker cyst, a popliteal cyst in the back of their knee. All those are along the spectrum of arthritis. And again, it's all based on symptoms and what has been done so far. So if a person comes in and I'm seeing them for the first time and they have never tried anything, again, my recommendation is going to be for conservative, because the goal is to try to keep that person out of the operating room. Because we can make, I like to tell a person, it's not always, you know the saying, it's not always green on the other side. We can make you worse than you are right now. A surgeon can make you worse, especially if that surgery is not done the right way. And you guys have heard that horror story of back pain, back surgery going bad, knee surgeries going bad. And so I like to tell patients, yes, you have severe arthritis, but that doesn't mean that we have to run to operating room. Because again, if you've never been treated for this, there's a great chance we can treat you conservatively and you do fine. On the flip side, if that person has exhausted every possible non-surgical therapeutic options, they've had physical therapy, they've had knee braces, they've had corticosteroid injection, they've had the gel injections, they've done pretty much everything. They've gone to a chiropractor, they have gone to acupuncture, they have done everything. And I see that they have severe arthritis. And that patient now is being affected not only just from a pain standpoint, but it's affecting their relationship, it's affecting their psyche. Then in that case, that's a person who is ideal for the operating room. And that's a person I would recommend having a surgery.
And most orthopedic surgeons I've spoken to are under the same purview that they usually like to wait. So this is really important to me because this is now where I come in. You come into the hospital and you come in with back pain and it hurts a lot. And we're going to tell you, no surgery, but we want you to do physical therapy and we want you to take these medications, which are probably going to be like NSAIDs, like ibuprofen or Tylenol, and do the exercise. But you're going to be mad at us because you're in pain and you're having trouble walking and moving, right? What he's saying is so important because you have to exhaust these non-surgical measures first. And the reason why we brought up what's serious and definitely needs intervention or surgery right now is because we wanted to talk, compare it to those reasons where you don't need surgery right away. What you need is some good physical therapy for several weeks, because it's going to take time, it's going to need work, or rest, continue with the stretches, the rubs, whatever it takes conservatively before surgery. You're going to be upset, but it's important to know that these things are important first. Very important.
Yeah, I tell patients when spine surgery is done for the right reason at the right time, it is very successful. But when you rush into it, when you don't gather all the information, and God forbid it's not done the right way, because that's another part of too, that's when you have bad outcome. But when I promise you, when spine surgery is done the right way, for the right reason, you will have success. But you have to have the right clinician, the right surgeon who listens to you, who holds your hands, walk to you along that treatment pathway. And if you get to the point of surgery, a lot of times you will not regret that you had that surgery. Maybe for the first 6 weeks or so, but after that, you'll be very satisfied. But it has to be done at the right time and for the right reasons.
And as we talk about conservative measures, there are patches, pain patches that you can use. When they come into the hospital, there's a Lauderdale patch that works really well. And we have things like these. You guys know diclofenac ointments, those ointments, right? Sometimes they work, right? So I have some here. And so these pain patches, these ointments, very good, very effective. Sometimes it's not going to be instant gratification, and that's what I'm trying to not push. It's not going to be instant. This is a pain. You pull a muscle. As you said, sometimes it can be a muscular pain. You hurt your back. You fractured your spine, and it's non-surgical approach at this time. It's going to be a marathon, unfortunately.
And, we are all here because, specifically here, because we believe in God, hopefully. Do not underestimate how fearfully and wonderfully God has made our bodies. Our bodies will heal itself. our bodies will heal. So I try to explain to my patient, the ones who are believers, the ones who are Christians usually get it a lot. It's easier for me to explain to them. But the goal is not, we can't all the time take away all your pain right away. I explain to them that the goal is to take away the edge, allow you to be functional, allow you to be able to get up and this is not like at the back of your mind, like constantly nagging you. Yes, you know it's there, but it's not something that's taking up your thought process your entire day. It's not the reason you're not getting up out of bed. And so the goal is to get you functional. And so because if you give your body enough time, your body a lot of times will heal itself. Just like my sister here said, somehow she got delayed in the referral. And what happened over time? The body got hurt. She got better because the body will heal itself. The body is so wonderful because the brain, it knows exactly what is wrong. It just needs the time. And so if we're patient enough, understanding that medications can't come. I tell patients the only way we're going to make you pain-free if we, sedate you. And we can't do that. We saw what happened with Michael Jackson. We saw what happened with all these other singers, trying to numb their pain, trying to get as much, trying to force their doctors to give them medication to numb their pain, to take it all away. And what happened? You get overdosed, it is not safe. So I try to explain to my patients, understand, we will not be able to take away all your pain. The goal is to take the edge off to where you're functional and just allow your body time to heal itself. And once those patients understand that, they're the ones who are coming back 3 months after and say, "Doctor, you're a prophet." I was like, no, it's not. It's just, it's God that has done the healing. Your body has done it, but I just kind of helped and guide you along that way.
All right, we have a question here.
I wake up in the mornings, I realize that my the fingers are stiff. And some of the times they look a little bit swollen. During the day, after a while, it will kind of go away. But then constantly, this finger, the ring finger, when you bend it like this and then to open it, the rest will open, but it feels like it kind of slide over the joint. So I don't know what is happening. It's a bit stiff. Then in the elbow of the right arm, I have little pains. And what will happen is that some things, if I grip it, I feel the pain in the elbow. And if I try to hold things with it, I cannot lift it easily, so I have to use this and to kind of help lift anything. Even if I put my hand in the cupboard and try to take down a dish or plate or something, once it is high up, I have the pain in the arm and the arms feel weak. It cannot really manage to pull it down easily. I don't know what it is.
Yeah,
but
so...
I remember my doctor told me, because I have... What do you call it? The one that hypothyroidism. And he says that too much calcium is in my bone. So I don't know. That's what he said. I have hypothyroidism and I have hypercalcemia. And I have hypocalcemia. So he says that too much calcium is in my bone, but he said I need to exercise. Hypothyroidism. That's what he said.
So you're describing a number of different things. It could be that one finger could be getting a little more arthritic than the other, but more so what it could be that you're getting what's called a trigger finger. Again, I would have to evaluate you again to see, but a lot of times we get triggering off our ring, it's our ring and our middle finger. And a lot of times, that's as we get older, that's what happens. And in the interest of time, it's hard to, I can explain to you maybe one way what's going on, but it sounds like you could be getting a little bit of triggering. The symptoms that you're describing when you wake up with the hands, that's classic arthritis. That's classic overnight because you haven't been moving the joints. It's kind of like, you think of it like a machinery. If you haven't used it, I know it's just overnight, so it doesn't seem like a long time, but think of it like a machinery. You haven't used it for a while. It takes a while to crank it up to have it going. And in this case, that's what's happening, that overnight, because you haven't been moving those joints, they get a little stiff. But like you said, as the day goes by, it gets better. So that's classic arthritis. With the elbow, again, that's hard to say whether or not, but the three things that come to my mind is it arthritis? Is it trigger? Sorry, not trigger. Trigger was the other side. Is it arthritis? Is it tennis elbow or golfer's elbow? So again, I would have to evaluate you and also get an x-ray to see what's going on, to know if it's one of those things or is it referred pain. Because sometimes you can have issue at other parts of your body that refer the pain to one ear or sends the signals to one. It feel like the issue is here, but it's coming from somewhere else, maybe coming from the shoulder.
At home, we do a little business for ourselves, and if I handle cane, and if I keep scrubbing things like this, I feel the hands keep moving, and it's constantly doing that, I realize it is affecting my arm. So as you said, it could go a tennis elbow.
Yeah, so when you constantly turn,
yes,
you have pain on your elbow?
Yes, in the elbow.
And where in the elbow?
Right in the joint.
So if it's in the medial, tennis elbow is on the outside.
Oh.
So medial elbow is golfer's. It's the same issue. It's just on different side. We call it a different thing. So it's a golfer's elbow. But if you're having the pain in the joint, tennis elbow or golfer's elbow doesn't affect in the joint, even though persons can be having the pain around the joint and they think it's coming. Again, I would have to take your elbow and range it, move it, and press on things to find out exactly the source or the point where the pain is emanating from and then get a better idea. But elbow doesn't have, outside of trauma, there's not a lot of things that affect the elbow except tennis elbow, golfer's elbow, or arthritis, right? Or sometimes, like the patient I'm going to operate on Monday, they have what's called cubital tunnel, where the ulnar nerve gets trapped on the medial side of their elbow. But usually those patients have weakness in their hands. They tell you they can't open a jar, they can't really grip. And in that case, we have to test you clinically to see how strong your muscles in your hands are. And if we're still not exactly sure, sometimes we may have to get a test called a nerve conduction test, an EMG nerve conduction test, to help confirm or diagnose. But usually between the cubital tunnel, which is the ulnar nerve neuropathy, the medial epicondylitis, which is the golfer's elbow or the tennis elbow, and arthritis, it's usually one of those four things. And I bet it's probably one of those things that's affecting you.
And you should get your thyroid. We have another question?
Yeah. Okay, 2020, I was running because I really love to jog. However, since then I don't. I had my knee was swollen and painful. I went to the orthopedic doctor and he did an x-ray. He said, well, he sent me to do exercise therapy. However, I couldn't do it because the knee getting worse. So the therapist recommended that he sent me to do an MRI to see what exactly was going on with the knee. However, it was diagnosed as torn meniscus, right? He didn't do surgery. He gave me a special brace to keep the knee and to wear to work for 3 months. However, from time to time, I do get real pain in the knee. So I'm wondering, does the torn meniscus heal itself?
So the minute you start describing what happened, I could tell you tore a meniscus. Mm-hmm. So you can have traumatic tears in the meniscus or you can have degenerative tears. And sometimes it's also that you had a degenerative tear that now you've aggravated because you're running and you did something when you were running, you kind of stepped on a stone or gravel or something without even noticing the wrong way and you kind of turned your knee. A lot of times that happens. Reassure you, most times it will get better. I can assure you if we get an MRI of everyone in this room, probably at least 70% of us have some type of torn meniscus if we're over age 40, right? So it is a very common issue. I know for sure I have a torn meniscus because when I work out, I feel it, but nobody is ever going to do anything to that.
All right.
Because again, it only bothers me when I do certain things. Yes. And so I just avoid doing those things. And guess what? I avoid it, and my knee's happy, and I'm happy. I don't have to have the surgery. There are some patients, they have, depending on the type of tear that they have, it can heal itself. But a lot of times, especially for what we call a peripheral tear, the tear is more, a central tear, the tear is more in the center. A lot of times those don't heal. And so what a surgeon will go in and they'll do is they'll shave it off. They go in and they, you say you get a cleanup. So they go in and they shave it off. I have my biases against that, but I'll just leave it at that. So, but if you can live with it, I would say live with it. Okay. And to answer your question, a lot of times, depending on where the tear is, it does not heal. It just becomes what we call asymptomatic. Your body gets used to it, and it just doesn't bother you anymore.
Okay.
But some tears will heal. It just depends on where it is.
My question is that if I do stairs, like when I'm exercising and I do stairs, yes, I feel it. So I try not to do it often. But still, I need to do stairs. Well, so.
So what I would recommend in your case then, because again, it doesn't hurt, and not for the same reason, I would try injection. Not that I'm not worried about chondrocytes, but I would try an injection because again, it may just, because what it is when you do the stairs, because of the way the knee, the mechanics of the knee, you're aggravating that tear. Like it's rubbing or pressing or moving abnormally against it, and just calming down the inflammation. If you again, my first recommendation would be to modify your activity and avoid doing that. But if you really like doing stairs, then I would say maybe just try an injection, because I promise you, one injection is not going to do anything bad to you. It's not going to make you gain, because one of the biggest myth is that when you get injection, you're going to get fat. You're going to put on weight. It will not cause you to put on weight, because the injection is not inside your systemic. It's not in the circulatory system. Okay? And yes, it can theoretically, if you have diabetes, theoretically increase the blood sugar a little bit. But again, if you just watch what you eat, and if you need to take an extra tablet, metformin or other, then you do that. But what I'm trying to say is one injection is not going to be detrimental. So that could be something you try to see if that allows you to go back to being able to doing stairs. Okay. You may say, Doc, is the injection going to last forever? No, it's not going to last forever. But maybe what it is that there's just so much inflammation that your body's not getting enough time to calm things down. And so that injection will calm it down because chances are you could have had that tear before you went running. Because remember I said you could have degenerative tears that get aggravated. And so you could have had that tear before, as well as it could be a new tear while you were running. And so chances are you could get that injection and it calms the inflammation down to the point now where it puts you back on a course where you can go back to doing what you used to do before, which is doing stairs. And even after the injection wears off, you're still fine because now you're back on that nice course. Yeah. And so that's what I would try if you really want to do it.
Dr. Ellis was saying about the cream. I have it, and I notice it does work. When it flares up, I'll use that, and it would help.
And when you say cream, you're talking about the Voltaren gel?
Yeah. The one I have is the prescription one,
Yeah, that's the same one, diclofenac.
Yes, right. Yeah, so.
Okay, so I just wanted to let us know that it is 7:48. So I just want to know if we're going to keep going, do more questions. You need to solve your back problem. All right, so I guess we're going to keep going. So next question, and then.
Oh, I thought you had a question, Pastor, no? Oh, I thought. Okay.
I think Sister Pam has a question. Go ahead.
I hear so many different ailments, and it's sad that I can say that I basically can attest that I actually have majority of what I'm hearing about. It's really sad for my age. But, but what happened in 2017, I was in a car wreck. And because of that, I was told that I wouldn't be walking like for about 2 or 3 years. So from 2017 until last year actually, I had to be doing, therapies and still going to a chiropractor, massages. It's just so horrific. My issue is that I thought I would have been healed like from 2017, but unfortunately, it's like it's more, worse because they're pushing for surgeries, which I don't want to do surgeries because like my neck, I was thrown forward. So I have neck herniated disc in my neck and my back. The sacrum always inflamed. I have sciatica, neuropathy, fibromyalgia, the list goes on. So all of those I was told that is from the accident. I'm wondering what can be done. When I went, like, coming to church, a lot of people are like, well, you're having all these pains. Why do you wear heels? And as you mentioned, my position, my posture, it helps with the heel, helps with my posture, but then I have to get out of the heels at a certain time to get in flats. Then when I get in flats again, the pain starts. So it's so confusing. Sometimes, like now my pain scale is basically on a daily basis up to a 9.
Right. So it seemed like you have a bit of a complicated history because of the accident. So what I would say, because you have a number of things, in addition to the accident, the trauma that it caused, you have fibromyalgia and all that. In your case, if you're not getting better, I agree that patients in your situation usually would benefit from some type of surgical intervention. But what I would also say is, if I'm the treating surgeon, I would first explain to you, these are the issues that are wrong, and I don't know what it is. But because of your other medical issues, I would be trying nerve blocks. Because again, if I can block your pain with the injection, then that's a good sign for me that my surgery that I will be proposing would be successful. But if I'm giving you nerve blocks and you're not getting better, then that's a very bad sign. Not necessarily mean that surgery won't be successful, but it's just, I will sit down with you and I will say, because if we're giving you nerve block, if I'm saying this is where your issue is, and we're there, and I know how spine is, for the most part, you can give a nerve block for pretty much a lot of things, And so if we can figure out and say, okay, this is the surgery that I'm thinking is going to benefit you, but I would want you to get this nerve block. So I'm going to send you to my pain management friend and say, please give her this at this area. And you could come back to me and you say to me, Doc, that did 0. You're going to have to take my hand and twist it real hard for me to operate on you. But if you come back to me and say, Doc, the first hour or so, I felt like I was brand new. But then after that, the pain, that's a good sign. See, patients always come back and then they say, this did not work. This did not work. And you say, hold on. Explain to me. When you got the injection, what happened? Yeah, I got it. I felt good. But by the next day or the next couple hours after, the pain was right. So that's good. That means it worked. It's just that your problem is so bad, it's so severe, that the block just lasted a short time. But that's a good thing, as opposed to when you say, at no point did it help you. So in your situation, I'd recommend trying nerve blocks first to see how successful they are, because you seem like you have a number of things. Based on just what you're telling me, you sound like you have some type of, sacral issues. It could be SI joint dysfunction. It could be fibromyalgia, it could be fractures or disc herniations in your lower back and your neck. And so I would say, okay, tell me what problem bothers you the most. Out of everything, which bothers you the most, and we'll focus on that first. And then we'll give nerve blocks, and then from there, based on the results, we'll talk about surgery. So that's how I would address or attack your problem. Mm-hmm. Right. Right. And so, again, so I heard someone said something about neuropathy. So you can have peripheral neuropathy, which is coming from damages to the nerves in the periphery, as the name implies. Or you can have radiculopathy, like I said earlier, where nerves are being squeezed. The way we can determine which it is would be that test that I mentioned earlier, nerve conduction test. Because a nerve conduction test can give us some information that based on the results, we'll say, okay, this is coming from the spine or this is coming from the periphery. And if it comes back that it's peripheral neuropathy, then chances are there is no amount of spine surgery that you're going to do that's going to help that problem. And in that case, unfortunately, I have to tell the patient, there's not much I can do from a surgical standpoint. Doesn't mean that there's nothing that can be done, but from a surgical standpoint, there's not much that we can do, but we have to address this from a medical standpoint. But to your point, what you're describing seems more like cervical radiculopathy rather than peripheral neuropathy. So I think you just need a proper assessment of your imaging, of your clinical status, and then go from there. Mm-hmm.
Which I have to assess for myself, because I have to help myself. Dieting, I have to do lots of walks, which limited because of the pain. But the medications and the side effects, I have to, assess that as well. One of the main issue, and that's not, I realize most doctors do not tell patients, because I have to bring that up to my doctor. The pain pushes my blood pressure high. And my doctor, I have to actually initiate it, telling them that, listen, that's what, because they're saying, oh, it's your diet. Or I said, no, it's not my diet. It's the pain. The pain scale can be so high as up to 10. But because I'm so used to it that it can go up to a 10, then my blood pressure goes aloof, so those are issues. And I think doctors should tell patients, sometimes it's not your diet.
Right.
It's the pain that you're feeling that causes that elevation. Yeah,
so the things that you're describing, like I said, you will be, again, especially if we can identify a pathology or something that correlates, you would be an ideal candidate for surgery, because after 2 years, if you're having these symptoms still, it's affecting your systemic, your system, meaning your blood pressure, and it's affecting your quality of life, then you'd be a candidate for, if I can identify a reason for the pain. And that's where you and I sit down and I say, this is what we recommend doing. This is what you will expect to get. And this is, versus what you have right now. And you and I will sit down and we'll make that decision together. And then you decide if you want to go through it or if you want to keep living with the symptoms that you're having. But after 2 years and the things that you're telling me, if you have something that's operable, it's probably worth, in this case, considering.
Okay, so
But again, I would try a nerve block first just to make sure that the nerve block works, because if the nerve block doesn't work, then that is not a necessarily, it doesn't mean that it's not possible that surgery will be successful, but it's not necessarily a good prognostic indicator either.
all right, I think we have to wrap up soon. We have 3 questions and 1 online, and then we'll probably have to wrap up. So,
Hello?
okay.
Okay, I know that cod liver oil tablet or the oil, the liquid, it's good to use on children for the bones. I am sure of that, but could I use it too to straighten our bones? Because I know it worked, because my daughter, one of her foot was straight and the other one looked like this. So when she was growing up, my mom said to me, give her cod liver oil to drink. But I didn't listen. So I take her to the hospital, and the examiner said they're going to break the leg and straighten it. So that was in Falmouth, so they sent me to Cornwall Regional Hospital. So when we go there now, we go to all the X-ray and everything. So I went back now to get the date to do the surgery. And the nurse that was taking care of me, she was there, and I was the next, we go from bench to bench. So when I reached the bench to be the next person to go in, I saw a nurse walk up. I didn't saw her all day, but all of a sudden this nurse just appeared to me. And she said to me, give me the docket. And I give it to her. And she said to me, go home and give the child cod liver oil to drink. When she said that to me, same time, I remember that my mother told me. So I get up same time and take the hands of my daughter. And when I walk off and go in and look, there were no nurse. And believe you me, our legs is straight today. So I'm wondering if it could work for us as adults too.
So
the cod liver oil could straighten our bones if we feel, maybe, I don't know.
So I do take cod liver oil tablets, but the reason I take it not so much for the bones, I take it for the brain. So it's good for neural tissue. So I take it because of the omega that's in there, and the DHA. So for me, I take it because, again, just doing my research, I want to either prevent or delay dementia and all that sort of stuff. So I take mine for brain health, for our, in this case, not just brain, but nervous tissue. And indirectly, I guess if the nerves are working okay, then that means the signals to the muscles are okay, and the bone, the movement of the bone is, but there's no direct link that I know of. But I do know that there's a lot of therapeutic benefit, a lot of preventative benefit of cod liver oil. But I also know so that again, we're here, and I hope that nobody takes this as a joke, because I myself, I can sit here and tell you guys, this is probably a whole nother topic, but I myself know that God is real. Like, God does miracles. I have been in surgeries, and things are going wrong. Things are going wrong. I'm inside the person's spine, and things are not, nobody else around me know what's going on, because I keep a straight face, I'm there operating, but things are going wrong. And I can't just stop and pray, because then everybody know what's going on, but I kind of do things, because a lot of them don't know what's going on. I'm just doing things there, buying time. And I'm praying, I'm like, God, this is out of my control right now. I cannot, and I can tell you stories. There is no doubt that God is in the business of working miracles. And I'm telling you, God has worked miracles in the surgeries that I've done. There is no way, everything was out of my control. I can tell you stories. So it could be that was an angel just telling you that God is going to take care of it right then and there. But I do know also that it's worth, to answer your question, it's worth taking cod liver oil, because I take it, and I know it's beneficial from my research. So, but I take it more to delay or prevent dementia or to keep my brain healthy.
Hello?
Oh, go ahead.
Yes. I too have the pain in my neck, in my arm, and in my chest. Sometimes I can't turn on the bed. Sometimes I cannot even turn in the bed. The pain is so bad. I went to the doctor, I got an injection. It lasted me the day. The other day, I'm back to square one.
Mm-hmm.
And she gave me gabapentin and another anti-inflammatory. Sometimes it doesn't work.
So
my friend here keep telling me that it's in my mind, but man,
no.
Yeah, she keep telling me it's in my mind. Because the pain is so bad sometimes it go right across my chest.
Yeah. So again, you're giving me some good prognostic indicators that something is wrong, because if you take a medication that helps, but now it's not fully taken, if you get a nerve block that helped you, but those are good reasons to tell me that there's something there that it's treating.
I did an MRI, and they told me that I had arthritis in my cervical spine.
Right.
I did some therapy. It helped for a while, and it has not been so bad. But now, for the past like 2 months, it is really bad.
So the patients, again, in my experience, that have done the best are patients that are just, I know when I say best, I'm talking about surgery. That have done the best are patients who have the stories that you have. The ones who they get better from therapy. It's not completely better though. The medications help a little bit. Nerve blocks, meaning epidural injections, ESIs or RFAs, they burn the nerves. Those different therapeutic interventions, they help. Those are the ones who I know for sure will benefit from surgery. One of the things I would also encourage you guys to try, do it very safely though, is because it can buy you time. When I say time, I'm not talking about weeks or months. It can buy you a good amount of time, years, is traction. So a lot of times when we go to a chiropractor and they say chiropractor help you and all that, all the chiropractor does is they do tractions. They do a little bit of manipulations, but a big part of what they do is traction. If you can get your own traction machine and safely use it, you get that same benefit whenever you want it at your home without having to spend, sorry if there's any chiropractor here, I didn't even, anyone listening online. But a big part is traction. So especially if you're having radiculopathy pain, radiant sciatic type pain, you get that, you get a cervical traction pillow and you pump it and you use it. That works a lot. You get inversion table for the lower spine or some type of lumbar traction. That works a lot, and that can buy you a lot of time and keep you out of the operating. So if you haven't tried that, that could be something to try.
Because I too was in an accident too. And I think it was the accident more than the arthritis.
Right, so try the cervical traction, but that would be something, because it seems like you're doing everything, the gabapentin, the medication, the injection, that's just the one thing I haven't heard you said, the traction. So I would try that, but in general, you sound like someone that if you do have to go to surgery, that you will benefit from it, once it's done correctly.
Okay, we have one more question. Sorry, we have to wrap up soon. I'm getting the wrap-up signal.
There is sorry. I was diagnosed with osteoarthritis. I have pain when standing and sitting. What is the best treatment for me? So again, it depends on how severe the osteoarthritis is. So again, we recommend activity modification. There's something that you're doing. For me, I tell patients, especially those with arthritis, osteoarthritis, nothing that's high impact on the joint. So for example, you're very rare to find me running anymore. I will run every now and again, but maybe a light jog, but nothing where I'm constantly impacting the joint and causing further wear and tear or damage. It's important to stay in shape, but you have to modify your activity, modify your exercise. So we're talking about using a recumbent bike, using, if you would like to, the act of walking or running, just walk.
Swimming.
Put the incline, you can swim, you could do rows. There's so many other cardio exercises that you can do. So modify your activity. If you're doing that, it's still painful, then I would start considering medication. You know, there are different types of medication, and one medication may work best for someone, another may not. You may have to try. There's so many. There's ibuprofen, there's Aleve, there is meloxicam, there's diclofenac, the tablets, you have the cream, you have the patches. There's so many different options that are out there. And again, one may work for one person, may not work for another person. If that is failing, you can have brace. There are braces that you can wear. There are also sleeves that you can use that will be helpful. Again, if those are not working, your exercise and nothing is helping, then in that case, then I say consider injection. Injections are very helpful. Again, when the injection is done the right way, it can be again, injection pays a lot of money. And so you'll go in, and some persons don't know how to do injection. They'll just stick a needle, and they don't know exactly where the needle is going, and they're not giving it the right place. So again, but injections can be helpful, and there are different types. Some say, oh, I got the steroid shot here or there, and again, it could be that they got it, the technique was right in one case and it wasn't right in the other situation. But just say the steroids is not working, you can try gels. The gels can work too. And if the gels are not working, you're trying everything. The last thing I would say is this is kind of the hard thing to tell a patient, but really and truly, sometimes do a self-reflection and ask yourself, do I need to lose some weight? Because a lot of times, it comes down, and you can see it. Sometimes it's hard for me to choose the politically correct words. So it's hard to tell a patient to lose weight because that's the only thing they hear a lot of times. And so I try never to tell a patient that. But a lot of times I do want to say something to that effect, and I really find another way of saying it, and I do say, but a lot of times that's what you may need to do, lose some weight. But if you're doing everything and it's not working, again, I can tell you, surgery done for the right reason, right time will be successful. There's a lot of patients out there that have a knee replacement 20, 30 years ago, and they're still doing fine. Because again, they exhausted everything, and if God is guiding you and God leads you to the right person, He still works through surgeons. Surgery doesn't mean that you failed. Surgery doesn't mean that you don't trust in God. Surgery doesn't mean that you're giving up or you're no longer a naturopathic, or it just means that you have a situation and this is the solution for it. And surgery can be successful, okay? So if everything else has failed, then I would just pray about it, and I know God will lead you to the right surgeon, and you would have that surgery, and you'll be one of those people coming in saying, oh yeah, I had my knee replaced 30 years ago, and it's doing fine.
Amen. Dr. Monroe, thank you so much for coming. It was a pleasure having him. Sorry, we have to wrap up. Absolute pleasure. I do have some Voltaren gels, and for those who have maybe osteopenia, osteoporosis, I have vitamin D, calcium supplements as well to give away, and some canes, but we don't know how to distribute, but we'll figure it out. So we're gonna wrap up. I'm sorry, we have to close. It's like after 8 o'clock, right? Okay, thank you.
If it's a question, I could talk to you after.
For vitamin D, Voltaren, over the counter? Yeah, it's just diclofenac 1%. I would say if you have heart failure, you probably don't want to, but yeah. Sure. I have a few of them for those who want. So. Thank you.
Okay, did you all enjoy this evening's talk? Amen. Do you feel well informed? And were your questions answered? We hope. Okay. And we'll figure out how to give out the canes. Okay. Health Ministries, and we encourage your feedback. Let us know what you want to know. Whatever topics you want us to cover, let us know, and we will AMB Health talk about it. We also have a AMB Health questions box in the lobby. It's a little green box. So if you have any questions or you have any requests of topics that you would like for us to cover, I'm going to leave that box in the lobby, and you can just drop those questions, those topics in that box, and we will get certified doctors, physicians, healthcare providers here to discuss those questions and get your questions answered. Amen? Amen. Again, thank you to our very own Dr. Renee Ellis for hosting this evening's program, and thank you to Dr. Brent Monroe for your presentation this evening, and we're looking forward for you to come back for a part 2, because they're already requesting a part 2. Amen? Okay. So in the interest of time, we are now going to transition into our Vespers thought so that we can guard ourselves, cover ourselves as we get ready to enter into the new week. And our Vesper thought will be given to us by Elder Charles.
Thank you, Sister Spence, and let me join my voice in thanking the doctors for coming to share with us this evening. That's one of the benefits of being a Seventh-day Adventist, all right? There's so much we can learn, and to God be the glory for what he has done. The doctor mentioned, and I thought he was going to steal my thunder here tonight, but he spoke about being fearfully and wonderfully made. Did you remember him? And in the book of, this passage comes from the book of Psalms. Turn with me, and I won't be very long. Psalms 139, verses 13 through 17. And it talks about, David talks about how God is so wonderful in the way he created us. And David says, "For you created my innermost being." Let's just think about that. You created my most innermost being and knit me together in my mother's womb. I praise you, for I am what? Fearfully and wonderfully made. Your works are wonderful. And David says, I know that full well. Do you know that you are fearfully and wonderfully made? My frame was not hidden from you when I was made in the secret place. No one knows what goes on as a child is being formed in his mother's womb.